The Aintree catheter is a 56 cm 19 French gauge semi-pliable catheter designed to accommodate a fibre optic scope, allowing the distal tip to remain uncovered and fully flexible to direct the scope and therefore the bougie into the glottis. The Aintree comes supplied with two RapidFit connectors, one for attachment to a standard 15 mm connector for bag and mask or circuit, and a connector for use with a jet ventilator. This allows oxygenation at any point as saturations dictate, or by using a bronchoscopic attachment, shown here, ventilation via circuit and ventilator can be implemented. For simplicity's sake, the following demonstration will not show this attachment. Careful note should be taken that the diameter of the Aintree catheter means the smallest tube that will fit over it is a 7 mm endotracheal tube, and care therefore should be taken when selecting an appropriate tube. With a standard LMA in situ, load the Aintree onto the scope. Attach the proximal end of the Aintree to the scope with some tape to avoid it slipping away. Insert the scope and catheter as a unit into the standard LMA and advance watching screen until the distal bars are reached, and aim to pass the scope between the vocal cords. Occasionally, resistance can be felt, as shown here, but this is usually due to the nature of the artificial mannequin. Continue to advance within the trachea until the carina is met. Release the folded tape, which is securing the catheter to the scope, and remove the scope completely. Advance the catheter again, only as far as 2 fingers of pressure will allow, to ensure the catheter has not slipped upwards. Deflate the LMA and remove completely, ensuring that finger contact with the Aintree is maintained at all times. This will prevent the catheter from accidentally being removed from the trachea. At this point, it is possible to attach the RapidFit connector to allow oxygenation if required. As a rule, connection to the 15 mm connector is likely to be safer than jet ventilation in case the catheter has entered a bronchus or a smaller airway, therefore causing barotrauma. Railroad the 7 mm or greater cut endotracheal tube onto the Aintree, again ensuring adequate lubrication. The cut tube is important to allow easy securing of the proximal tip of the catheter without having to withdraw the Aintree too far and risk removing it from the airway. Once the proximal end of the Aintree is seen and held coming through the endotracheal tube, reinsert the scope completely into the catheter as in the initial unit. This combined unit ensures the catheter functions as a bougie while railroading the endotracheal tube and allows you to watch the carina whilst railroading the endotracheal tube to ensure correct placement. Remove the unit and inflate the endotracheal cuff. Ensure appropriate length at the lips and commence ventilation. The Pro Seal has been shown to work well with the Aintree catheter and may be preferred over classic style LMA by some in certain clinical scenarios. The Supreme is now also frequently being used clinically for routine anesthesia, but some doubt exists as to whether it will limit the manoeuvrability of the scope tip and hence reduce your chance of manipulating the scope into the trachea.